Assalamu alaikum. My name is Dr. Usman. I am resident urology in SIUT Karachi, and the topic of my presentation is imaging in prostate cancer. What urology? What a urologist should know. And my moderator is Dr. Rabiullah. First of all, I will briefly discuss the anatomy of prostate, and after that I will discuss the various imaging modalities used for the diagnosis of prostate cancer nowadays. Prostate anatomy. From above down, prostate is divided into base, the midgland, and the apex. In axial plane, the prostate has anterior fibromuscular stoma, which contains no glandular tissue, the transitional zone, the central zone, and the outer peripheral zone. In this image, we can see that this is the peripheral zone, this is the central gland. Here we can see that from above to downward, this is the base of the prostate gland, this is the midgland, and this is the apex. Here we can see that the peripheral zone increased from above downward. Moreover, neurovascular bundles are present on the lateral side of the prostate gland. The volume of peripheral zone increasing from base to apex, and 95% of prostate cancer are adenocarcinoma, which arises from the prostatic ducts. And most of the prostate cancer arise in the peripheral zone, and 70% originating in the peripheral zone, followed by transitional zone, where it is 25%, and 5% only arises in the central zone. On imaging, it is difficult to differentiate transitional zone from the central zone, and they both are collectively called central gland. The various imaging modalities which are used for the diagnosis of prostate cancer are transrectal ultrasound, CT scan, multiparametric MRI, bone scan, and PET scan. Transrectal ultrasound. The main role of transrectal ultrasound is in prostate biopsy. With the development of microbubble contrast, TRUS has now played a role in the detection of prostate cancer. We all know that the tumor is highly vascular. Because of the increased angiogenesis in the tumor, microbubble contrast helps in detecting the prostate cancer, which I will discuss later in detail. When prostate cancer is suspected, the diagnostic test of choice is systemic needle biopsy with ultrasound guidance. Core are typically obtained from the 6 areas of sextant biopsy from the left and right apex, left and right midgland, and left and right base. These are the images. Here we can see that this is the hypoechoic lesion. This is a transfer section, and here we can see the hypoechoic lesion, which is most likely prostate here. This is rectal view. Here we can also see that hypoechoic lesion is present, and the capsule is intact here, smooth. So this is a tumor confined, organ confined disease. In past, it was considered that the hypoechoic lesion on transrectal ultrasound was considered pathognomic for the diagnosis of prostate CA. But this view has changed now, because many cancers are detected at biopsy which are not hypoechoic lesion on transrectal ultrasound. Moreover, there are many isoechoic lesions which on biopsy are detected as cancer. On transrectal ultrasound, there are some features which suggest that there is extracapsular extension, like bulging or irregularity in the capsule. Increase in length of contact of the lesion also shows that there around the capsule also depicts that there is extracapsular extension. Here we can see that this is hypoechoic lesion, and this fuzzy capsule here depicts that there is capsular involvement and extracapsular extension. Seminal vesicle invasions. On transrectal ultrasound, visible extension of hypoechoic lesion into the seminal vesicle or echogenic cancer within a normally fluid-filled seminal vesicle show seminal vesicle invasion. Asymmetry of seminal vesicle and solid hypoechoic masses within the seminal vesicle are indirect evidence of tumor extension into the seminal vesicles. TRUS continues to play an important role not only in the diagnosis but also in the treatment of the prostate cancer. TRUS is used for guiding brachytherapy seeds in the prostate CA. It has also played a major role in cryotherapy and high intensity focused ultrasound. New modalities in which prostate CA is destroyed using hyperthermia or photodynamic therapy are also dependent on transrectal ultrasound. So in developed countries, scientists are working in injecting oncolytic viruses in prostate cancer, tumor vaccine, and gene therapy to cure prostate cancer. All these modalities depend on transrectal ultrasound for the guidance. One of the great invention of the transrectal improvement in the transrectal ultrasound nowadays is microbubble contrast agent. We all know that the prostate cancer is highly vascular. Angiogenesis is essential for tumor growth and invasion. And in tumor, there is increase in microvessel density. In microbubble contrast, quantification of blood flow allow us to assess the prostate cancer. 4 indices are measured in this technique: bolus arrival time, time to peak, area under curve, and wash in and wash out. All these indices help us in detecting prostate CA. Scientists are now working in developing some targeted agent which will have oncolytic properties and will have affinity for cancer and for prostate cancer cell. They are hopeful that they will attach to the prostate cancer cell and help in destruction of the cancer. Moreover, with 3 and 4 dimensional images, they believe that it will help in the detection of the prostate cancer and evaluating the total size of the prostate cancer. CT scan has virtually no role in primary prostate cancer detection or this staging of the disease. The main role of CT scan is only in the nodal staging. CT scan also helps in identifying the bone metastasis, but bone scintigraphy and MRI is considered superior to CT in this regard. Latent and blastic bone metastasis will be commonly visible at CT. Here in picture, we can see that enlarged lymph node around the external iliac vessel. MRI is used in diagnosis of prostate cancer since 1980. Initially, it was used in local staging of the disease. And there were 2 standard images: T1 images, which better show post-biopsy hemorrhage, and T2 images, which better explain anatomy and extra-prostatic involvement. Whenever we talk about the MRI, the main currency in the MRI is signals. With the improvement in magnets in the past years, there is improvement in the overall quality of the MRI. Nowadays, 1.5 Tulsa magnet along with endorectal coils or 3 Tulsa magnets are usually recommended. Multiparametric MRI. This is the newest modification in the MRI which is used for assessing the prostate cancer. It consists of standard T1 and T2 weighted images, diffusion weighted images, and ADC mapping, dynamic contrast enhancement. Previously, MR spectroscopy was also included in multiparametric MRI. Multiparametric MRI tells us about the local staging of the disease, in detection of clinically significant prostatic cancer, in localization of the disease, risk stratification, recurrent disease, and focal therapy. On normal T2 weighted images, the peripheral zone has homogeneous high intensity signal, whereas the central zone has variable amount of intermediate signal intensity. In prostatic cancer, the low T2 signal intensity replaces the high signal intensity in the peripheral zone. In transitional zone tumor, a homogeneous region in the transitional zone and lack of low intensity rim shows prostatic cancer. This is the normal images of T2 images. Here we can see that these are the changes because of BPH, and this is the low intensity rim. Here this is the hyperintensity peripheral zone of the prostate and intermediate signal central gland. Here we can see that the prostate cancer in the left peripheral zone, and it is there we can see that low signal in the peripheral, low intensity signal in the peripheral zone. Then there are certain criteria which show extracapsular extension on T2 images, asymmetry of neurovascular bundle, encasement of neurovascular bundle, bulging in prostate contour, irregulated or speculated margins, and obliteration of prostatic angle, capsular retraction, tumor capsule interface greater than 1 cm or breach in capsule. All these are evidence which shows that there is extracapsular extension. Features which shows that there is seminal vesicle invasion is disruption or loss of normal architecture of the seminal vesicle. Focal low signal intensity within and along the seminal vesicle. In large low signal intensity duct and seminal vesicle. Obliteration of angle between the prostate and seminal vesicle. Demonstration of direct tumor extension from the base of the prostate into and around the seminal vesicle. There are certain limitations of T2-weighted images. Prostate tumor. So there are some prostate tumor which are iso-intense and are difficult to identify on T2 images. Moreover, there are certain lesions like prostatitis, scarring, atrophy of prostate gland, which are hypoechoic or have low intensity signal on T2 images. Sometimes post-biopsy hemorrhage also hampers with the diagnosis of prostate cancer. Moreover, the heterogeneity of the signal intensity in the transitional zone also interfere with the diagnosis of prostate cancer, and it is difficult to diagnose it on this. Now, diffusion weighted images. This method uses random motion of water molecules, that is Brownian motion, which is random motion of water molecules in the extracellular, intracellular and intravascular spaces. These movements are restricted in case of malignancy, ischemia and abscesses. In cancer, there is increase in number of cells, and all the cancer are, as we know, hypercellular. So there is decrease in extracellular space. As a result, there is reduction in the motion of the water molecules. This method is used for detection of the prostate cancer. Diffusion weighted images provide us with the quantitative biophysical parameter that is used to differentiate prostate benign disease from malignant prostate tissue. Diffusion weighted images also help us in diagnosis of the recurrent disease. In the patient which is previously treated with the surgery or in some other manner, the increasing PA and subtle changes in apparent diffusion coefficient shows that there is recurrent disease. It also diffusion weighted images also helps us in finding nodal metastasis. The contrast used for this purpose is lymphotrophic superparamagnetic nanoparticles. They are injected, they are taken up by the macrophages, and macrophages carry them to the nodal tissue. These contrast labeled macrophages cannot gain entry into the malignant nodes. In this way, we can diagnose the lymph nodes, the malignant lymph nodes, which even do not meet the standard size criteria for the metastasis. Dynamic contrast enhanced imaging. Dynamic contrast enhanced imaging is an advanced prostate imaging modality that allow derivation of parameters that are closely related to the microvascular and angiogenesis of the tissue. In this method, the contrast, which is gadolinium chelate, is injected. The dose is 0.1 millimole per kg, and serial 3D acquisition are obtained every 2 to 5 seconds through the prostate. Prostate cancer shows early, rapid and intense washing and rapid washout. In this, the rapid washout is more significant for identifying prostate cancer from the benign diseases. Microvascular alteration and neovascularity are in general more severe in prostate cancer in comparison with the other processes in prostate, such as BPH and prostatic intraepithelial neoplasia. However, there are some tumors which are mildly or moderately hypervascular, and they are not detected by this method. Extracapsular extension or seminal vesicle invasion. On dynamic contrast enhancement, abnormally high or asymmetrical peak enhancement, contrast agent washout, short onset time and short time to peak shows seminal vesicle invasion. Similar findings if detected near the neovascular bundle or rectoprostatic angle shows extracapsular extension of the prostate CA. This is the multiparametric MRI. Here we can see that this is the high intensity peripheral zone of the prostate gland. This low intensity signal shows that this is prostatic carcinoma. On diffusion weighted images, there is increased uptake of, there is high intensity signal in the corresponding area with high B values. High B values are usually associated with prostatic carcinoma. On ADC mapping, the corresponding area has low ADC apparent diffusion coefficient, which also shows that it is most likely a prostatic carcinoma. Then this is dynamic contrast enhanced scan, where there is early, rapid and intense washing followed by rapid washout. Now keeping in view multiparametric MRI, a European Society of Urogenital Radiology developed PI-RADS score system for the assessment of prostatic cancer. And they have improved it over the years. This scoring system tells us about the likelihood of clinically significant cancer to be present. It is based on the three parameters of the multiparametric MRI: T2 weighted images, diffusion weighted images, and dynamic contrast enhancement. And each of these parameters has given score 1, and the total score in this scoring system is from 3 to 15. In some studies, score of 8 or higher, while in other 9 or higher is considered significant. Keeping in view this scoring system, the PI-RADS is divided into 5 stages. PI-RADS 1, which has very low risk of cancer, and PI-RADS 2, which has also low risk. PI-RADS 3, 4, and 5 have high risk of prostatic cancer. These stages are also related with the Gleason score of the prostate. Similarly, there is LIKERT 5-scale scoring system. It was given by prostate diagnostic imaging consensus meeting and has improved over the time. It is also divided into 5 scales from 1 to 5. LIKERT 1 and 2 have very low risk of prostatic cancer, while 3, 4, and 5 have increased risk of cancer and need biopsy. The significance of this score is that it is related with the tumor volume and Gleason score of the prostatic cancer. And mass spectroscopy provides us information about the biochemical and metabolic environment of the tissue, and it is increasingly being used as biochemical for the detection of prostate cancer. MR spectroscopy requires multivoxel volume selection technique. We know that citrate is found in high concentration in healthy prostate epithelium and prostatic fluid. It is found in low concentration elsewhere. This principle is employed in detection of prostate cancer. The normal prostate has MR spectrum with prominent citrate peak at 2.6, which is usually doublet with occasional visualization of small additional side peaks. A decrease in citrate level is found in prostate cancer as well as in prostatitis and hemorrhage. Choline is represented at 3.2 ppm. Owing to increase in cell membrane turnover and increase in cell surface compared with the cell volume in cellular tumor, choline concentration are increased. Increase in choline signal or concentration is considered to be spectroscopic hallmark for the detection of the cancer. And it has been found in benign cancer. However, it has also been found in benign condition of prostate such as prostatitis. An increase in choline to citrate ratio or choline plus creatinine divided by citrate is often used as a marker of malignancy in prostate cancer and increases the specificity in the diagnosis. However, it is most reliable only in the peripheral zone. This is the image of the normal prostate gland. Here we can see the citrate peak with 2 side peaks. This is the prostatic CA. Here we can see the choline peak. However, the MR spectroscopy has limitation that the findings overlap with the BPH and prostatitis. MR spectroscopy, when combined with anatomical imaging, found to increase the accuracy of tumor volume estimation in prostate CA. Nowadays, MRI is also used in developed countries for guiding the biopsies because MRI imaging provides more detailed anatomical image of the prostate than transrectal ultrasound, because it has shown to be a most accurate imaging modality for localization of prostate cancer. Nowadays, MRI fusion biopsy is quite famous. In this, MRI is performed 1 day prior to the biopsy day. On biopsy day, the software is used to fuse the MRI scan with the transrectal ultrasound, and targeted biopsies are performed. Transrectal MRI imaging is also used in guiding prostate brachytherapy. Here we can see that this is the endorectal coil which is used for the for MRI, while this is the MRI images, and these are the software which later fuse both MRI findings with the transrectal ultrasound, and targeted biopsies are performed. In development countries nowadays, robotic prostate biopsies are also performed using MRI guidance, and they are of belief that they will have high accuracy as compared to the other methods. Bone scintigraphy or radionuclide bone scanning. It has no role in detection of prostate cancer or its primary staging of the disease, but it is a diagnosis. It is the investigation of choice for identifying the bone metastasis. A focal area of increased radiotracer uptake is usually found in the skeleton. Whenever prostatic cancer metastasizes to the bone, there is increased osteoblastic activity within the bone, and this is taken up on the radionuclide scanning. Altered marrow signal intensity are also seen in infection, infarction, and trauma. So sometimes they mimic as if there is malignancy. This is the image of the bone scintigraphy, and here we can see that increased uptake in the axial imaging, axial skeleton. Radionuclide bone scanning can also be used to see the response to the treatment of prostate cancer. Various treatments, chemotherapy, hormone therapy, and radiation were used for this purpose. After that, there should be decrease in the radiotracer uptake in the on bone scintigraphy. However, while seeing this, we should keep in mind the flare phenomena, in which there is initially increase after chemotherapy or hormone therapy in the uptake of radiotracer. This is because of the increased bone turnover during healing. This usually happens for the initial 6 weeks. So we should keep in mind that while evaluating the response to treatment of the patient. PET imaging. Positron emission radioisotopes are used in this imaging technique. Various radioisotopes are used. Most common nowadays is a glucose analog, fluorine-8-fluorodeoxyglucose. Cancer, we all know that cancer has high metabolic rate and poor glycolytic pathway, both of which leads to increase in glucose analog uptake. On PET-CT, they provides us information about the location of the tumor in the prostate bed. Moreover, it also throws information on the pelvic lymph nodes, about the involvement of the pelvic lymph nodes. FDJ has limitation in this regard because it sometimes it is confusing in case of inflammation in the gland. So scientists are now working on developing new radiotracer which will improve this imaging technique. This is a simple CT scan. Here we can see there is no, here we cannot appreciate any prostatic CA. This is grayscale PET scan. This is the PET CT with FTJ contrast, where we can see that increased activity in the left zone of the prostate. Moreover, there is similarly increased uptake in the upper region of the bladder, which is most likely because of the prostatic CA. Nowadays, scientists are working on the various new techniques. They are thinking of replacing diffusion rated MRI with new techniques like luminal flow MRI, and they are working on it, but no data is available right now on that. These are the various imaging modalities which are used for the diagnosis of prostate CA and its staging. Thank you.
Any question and queries? Ji Aisha.
Usman, can you go to the slide when you had showed the extracapsular extension of the prostate CA imaging and using extraprostatic extension? So when we talk about the T staging of the prostate cancers, we say that this T staging is clinical and it's based upon the DRE findings. So when this extracapsular extension is considered, which is T3A, how can that be labeled on a simple DRE finding? Because and then what is the role of imaging in this in diagnosis of T3A?
Basically, the staging, as we know, the T stage, on DRE we can detect up to T2C involvement of the both lobes, but the extracapsular extension is difficult to assess on the DRE. So we need some imaging like MRI. It's also some less sensitive but more specific for the detection of extracapsular disease, because the further treatment and the management depends on the proper staging. Even the lymph node staging is very controversial with CT and MRI because they are not that sensitive to detect the extracapsular disease.
So then we can say that for the to label the disease at T3 or T4 we need imaging, and we cannot say that they can be diagnosed clinically as is labeled in the books and guidelines that all the T staging are based upon DRE finding and imaging have no role in it.
T3 and the further is basically diagnosed on imaging. You cannot detect clinically. No other question? Yes.
I was reading one paper. There was mentioned that prostate secretes citrates and cholines.
Yes.
And in malignancy, citrates are low and choline level is high. So anything further you want to say in it? Because I read these 2 lines in that article, and this citrate thing was new for me.
So basically, there's an investigation, MR spectroscopy, which detects the metabolic activity in the prostate. So MR spectroscopy basically tells this, but this is less specific because it's also found in the prostatitis and other inflammations. So it is not specific for cancer only. So that is the issue, and therefore MR spectroscopy is not done routinely. Multiparametric MRI, initially it was a part of multiparametric MRI, but routinely it is not done because loss of specificity.
So the diagnosis of prostate cancer is initially when there was no MRI, TRUS or the certain things. The diagnosis was clinical, and initially the TNM staging has been made on the basis of clinical ground, whether on the DRE it's up to clinical stage like T2C or both lobes involved on the DRE or not. I think nowadays the technology has extended at its peak that there are many things to do to detect the prostate cancer. Initially for the non-localized prostate cancer, which is inside the prostate, we can't feel with the clinically with the DRE, and up to the level of extra prostatic extension. Sir, do you think that the TNM staging that is still is going on the same? So does it need to reconfigure or re-image that on the basis of these modalities that are very specific and sensitive to detect the prostate cancer, it can be remodulated?
You see, when we talk about staging, we have to be very clear that when a small c is attached to anything like TNM, then it includes not only your finger, your hand, your palm, which you feel, and but also something called imaging. So this is all also clinical. Short of anything of say something like biopsy, which is pathological, everything is clinical. So whenever you want to stage something, then it has to include imaging. Whether we are talking about prostate or bladder or kidney cancer, clinical means everything that comes in the realm of imaging, plus whatever you want to inspect, palpate, percuss or auscultate. So all 4 things plus the 5th thing is imaging. Now what in the context of prostate, what is available is a lot of things. Not only something which is as good as multiparametric MRI, which we think is the maybe the final verdict on prostate imaging, but there are many things available. You have mentioned one point in your slide about radionuclide. Yes, maybe it is out for the purpose of staging, but scanning is not out in terms of staging. For instance, maybe 20 years back, it was something called capromab. Now, capromab is actually an antibody, and it's a monoclonal antibody. So there was a scintigram which was proposed for the detection of prostate cancer, and that is known as ProstaScint scan. That was based on the premise that if we develop something called a molecular marker for the detection of prostate cancer, then whether the prostate cancer is confined to the prostate or it has metastasized to the bone or anywhere else, that monoclonal antibody will go and just attach itself to that area, and that will glow up on a scan. So that might be something which is out of fashion now, but it is still on the horizon, and there are many things which are available. If you go back just to maybe 1 week back, there was something on Twitter regarding the same thing, and I don't remember, and I was just going through my my pages, the Twitter pages yesterday, but couldn't find it. But when I find out, I will let you know that there is something which is on the horizon in this context also, and it has been lately proposed as something which can be taken in advance of something which is like parametric MRI. So you are not only going towards multiparametric MRI, you are also having, as I have said earlier on, monoclonal antibody for the detection of prostate cancer, but also something which is as innocent as transrectal ultrasound. There is now a multiparametric transrectal ultrasound. This is low cost. It is giving you a lot of definition in more details as compared to multiparametric, which is rather costly. For that you need to have 3 Tesla. And the kind of MRI which are available in Pakistan is not more than 1.5 Tesla. So it needs a lot of investment also, and let's see what happens next in this context of imaging. But again, coming back to your question, when we say clinical, it means you have to include all these parameters, the imaging parameters, together with what you examine. That gives you a picture which is clinical, and then you move on to pathological.
Any question? Resident or registrars?
Yes.
You have discussed about FDG PET-CT, but there is role of PSMA PET-CT. And PSMA PET-CT now it is evolving also in non-metastatic but CRPC. So we know the indication of PSMA PET-CT also.
Actually, we were talking about something which is in the primary setting, in the diagnostic workup. I don't know whether PSMA PET-CT is something which is for primary detection, is it?
No. It is not for primary detection.
Right. So we were just talking about the diagnostic aspects, for the primary disease.
So thank you.
Thank you.